Hello, it's Dmitry again. Today I'll be continuing on with the internal medicine PDF from Mehlman Medical, talking about, this is going to be the third video we have, particularly on the, I believe it is, neurology section. So let's get back into that. We are on page 262. We should wrap up on 278, so this should be not too crazy, I don't believe. But let's see. Infective neuropathies. Polio. RNA virus that infects the anterior horns of the spinal cord and causes poliomyelitis, inflammation of the spinal cord. Classically causes degeneration of the motor neurons in one leg, leading to one leg much smaller than the other leg. Highest yield points about polio actually have zero to do with the infection, almost all to do with the vaccines. Salk vaccine is the killed or intramuscular vaccine. The Sabin vaccine is a live attenuated oral vaccine. USMLE will ask you what is a common feature that those vaccines and what that accounts for their efficacy. The answer should be neutralizing antibodies in the circulation. Only the live attenuated vaccine is capable of generating a CD8 positive T cell response and IgA secretion in the gut. However, both the killed and the oral are capable of generating IgG antibodies in the circulation. If you're confused about the immuno, I talk about this stuff in my high yield immuno PDF. PML, progressive multifocal leukoencephalopathy caused by the JC polyomavirus. Presents as a neurodegeneration over the weeks to months in the immunocompromised patient, that is to say, AIDS patients with a CD4 count less than 100, patients undergoing chemoradiotherapy, or those on immunosuppressant drugs. USMLE wants you to know that this condition is due to the reactivation of latent infection, which means that the patient is infected at some point during life years ago. But the condition now manifests due to the immunosuppression. Acute infection in immunocompromised patient is the wrong answer. So it's not acute infection in an immunocompromised patient. The answer should be, as we said before, reactivation of latent infection, because it's sort of this latent virus that's hanging out in the body that's only going to pop up again because of a compromised immune system. TSP, tropical spastic paraparesis. That's an interesting tongue twister. Obscure neurologic condition caused by HTLV1/2, the same virus that causes mycosis fungoides and Sézary syndrome. If you were like, oh my gosh, what the flip, I discussed these in my high-yield derm PDF. Development of the antineuronal antibodies that presents as a neurodegeneration. SSPE, subacute sclerosing panencephalitis, obscure condition characterized by cognitive decline and neuropathy due to the reactivation of certain strains of measles in the central nervous system. Will present as a teenager experiencing cognitive decline plus CSF analysis shows measles. Toxin-induced neuropathies. Botulism causes flaccid paralysis. Botulin toxin of Clostridium botulinum inhibits the presynaptic snare protein, resulting in a decrease in the release of presynaptic acetylcholine, which is normally stimulatory at muscles. It can present as a floppy baby syndrome. It can also cause cranial nerve palsies. USMLE can be weird about the answer, where I've seen them write on an MBME exam something along the lines of prevents acetylcholine from binding to its receptor as the MOA of the toxin, even though this isn't technically the direct effect. The acquired as spores in honey in infants under the age of 1, acquired as preformed toxin from canned goods in anyone older than that, so like adults or whatever, but even in theory, other kinds of kids. MBME exams want you to know that the administering toxin does not change the effect of the strength of the effect of it. Toxin does not change the effect of the strength of the effect of the acetylcholine binding to its receptor. Well, that's kind of okay. Whatever that means. It's kind of a goofy way to phrase it. A little bit confusing. This is because the toxin isn't a competitive inhibitor, plus only the decrease in endogenous acetylcholine release. This has no impact on acetylcholine administered exogenously. So this toxin does not change the effect of acetylcholine binding to its receptor. Let me phrase it like that. This toxin does not change the effect of acetylcholine binding to its receptor. So, okay. Tetanus. Tetanus causes spastic paralysis. Tetanus toxin Clostridium tetani inhibits presynaptic snare protein, resulting in a decrease in the release of presynaptic neurotransmitters, GABA and glycine, which are normally inhibitory. Can present as opistonos, arch back, and trismus, locked jaw. Presents in 2 patients in USMLE, neonate born at home whose umbilical cord was cut with a kitchen knife plus tied with twine. Okay, that's interesting. Random dude who was cut himself in the backyard, DTaP given 2, 4, 6 months, and then 15, 18 months, then again at 4 to 6 years. School-age kids require Tdap booster at 11 to 12 years, followed by a TD booster every 10 years thereafter. Pregnant women should get a Tdap at 27 to 36 weeks to protect neonate from pertussis. For cuts/wounds post-vaccine, 0 to 5 years post-vaccine, no treatment is necessary. 6 to 9 years at post-vaccine, if clean wound, no treatment. If dirty wound, give a TD booster. 10 plus years post-vaccine, if clean wound, give TD booster. If dirty wound, give an IVIG plus vaccine. In other words, only ever give IVIG when it's a dirty wound has been 10 plus years. Okay. So tetanus for the dirty wounds you find. Fair enough. We were always taught about that, about like when I was younger, about rusty nails, but like apparently they're not. That's not the criteria. It's dirty wounds is what they're talking about in general. What about tetrodotoxin? Toxin acquired by pufferfish, inhibits sodium channels, causes paralysis and death. Ciguatera, toxin acquired by various meaty fish, prevents sodium channel closure. The answer on USMLE for temperature dysesthesia: hot feels cold, cold feels hot. Narcolepsy, chronic sleep disorder affecting the brain's ability to regulate sleep-wake cycles normally, characterized by excessive daytime sleepiness, sudden episodes of muscle weakness, cataplexy, sleep paralysis, and hallucinations. The latter tends to occur prior to sleep, hypnagogic, or upon waking up, hypnopompic, thought to be due to the deficiency of a neurotransmitter called orexin, aka hypocretin, which normally promotes wakefulness. Treatment is modafinil, dopamine reuptake inhibitor, plus promotes release of orexin from the hypothalamus. Brain bleeds. Epidural hematoma, rupture at midlife meningeal artery, branch of the external carotid, classically occurs following head trauma to the temple. Lucid interval, that is to say, patient loses consciousness briefly followed by arousing and returning to normal, for example, that is to say, has a brief period of lucidity, then goes home thinking he or she is okay, then goes to sleep, then dies. Well, that's not desirable. Bleed appears as a lens, biconvex, fast accumulating, so biconvex lens shape. If low GCS, do intubation plus hyperventilation, then do craniotomy. If normal GCS, what does GCS in this context mean? GCS, I want to say, I don't actually know. I don't know. GCS hematoma. Let me look that up right now. GCS hematoma. GCS refers to the Glasgow Coma Scale. Well, thank you for that. So I don't really like acronyms when they're throwing it around sometimes when I don't really know what they're talking about. They threw some acronyms before when they might explain it, and other times they just explain it. They just say acronyms out, and they expect you to know what on earth they're talking about, which is crazy. You have low GCS, do intubation plus hyperventilation, then do craniotomy. If the Glasgow Coma Scale is normal, just do craniotomy. Hyperventilation mechanism decreases the CO2, decreases the cerebral perfusion, reduces the intracranial pressure. Oh, that's interesting. So that's what a epidural hematoma looks like. It is this sort of bleed where it's a lens shape. Again, what we want to do is craniotomy regardless, but if the patient has if the patient, for example, has a situation where they have a low GCS, a low Glasgow Coma score, they also have to do hyperventilation with intubation, in addition to a craniotomy. What about subdural hematoma? And we can see that right there. It looks like a crescent shape. So subdural hematoma, rupture of the bridging superior cerebral veins. No lucid interval, i.e. patient did not lose consciousness. Crescent shaped, can be slowly accumulating and heterogeneous in appearance due to the combination of dried plus fresh blood. Increased risk in elderly/dementia and alcoholics. Answer in acceleration deceleration injuries, shaken baby syndrome, motor vehicle accidents. NBME wants a craniotomy as the answer for treatment, no evidence for mere observation as the answer on any of the USMLE material. So even though you could say, well, can't you just kind of see how it goes? For NBME, no. The answer is no. You have to do craniotomy is what they're saying. That is the answer. If the patient has a decreased Glasgow score, to do intubation plus hyperventilation as the answer before craniotomy. So again, it's like the epidural type, where even though it's a different origin technically and has a different presentation, the actual solution is basically the same. If they have this condition, or like the previous one, you got to do craniotomy, and if they have this low Glasgow score, you have to do a intubation plus hyperventilation before you do the craniotomy. What about subarachnoid hemorrhage? Well, in that case, rupture of the anterior communicating artery, ACOM, or posterior communicating artery, PCOM, saccular berry aneurysm. ACOM is more likely than PCOM in terms of the location. Patients often reports worst headache of his or her life. Can present with stiff neck, meningism, the same way meningitis does due to the irritation of the meninges by the hemorrhage. This often confuses students as it is very high yield detail. So let me read that again. Can present with stiff neck, meningism, the same way meningitis does due to the irritation of the meninges by the hemorrhage. Okay. Be aware of that for subarachnoid hemorrhage. It sounds like meningitis, but it's not, okay? But there's obviously some overlap in presentation because of what it's acting on. Make sense? PCOM aneurysm, classically associated with the ipsilateral blown pupil, mydriasis, due to the cranial nerve 3 impingement. Hypertension is most commonly a risk factor in populations and accounts for most cases. Ehlers-Danlos and autosomal dominant polycystic kidney disease, or ADPKD, are high-yield non-hypertension associated with specific causes of saccular aneurysms. A patient with a hypertension is still more likely to die from myocardial infarction than Berry aneurysm, which is asked on NBME. So again, still more likely to die from MI. But if the patient has a Berry aneurysm, it is more likely from hypertension. So a patient with hypertension is still more likely to die from MI than Berry aneurysm, but if the patient has Berry aneurysm, it is more likely from hypertension. Okay, so what they're saying is even though Berry aneurysms are going to be associated with hypertension, you're still more likely to die of MI. Okay? So even though there's a correlation between Berry aneurysms and hypertension still is the bigger issue for hypertension is still heart attacks. Okay? Bleed appears like a starfish or sand dollar. Question can say there's a blood visual. As far as I know, I would assume what they're talking about is that there's a correlation, but that the correlation between that with hypertension and MI is stronger, is my assumption. And maybe they're implying that heart attack is still a bigger issue in theory. Maybe. I'm not quite sure exactly what they're trying. I'm trying to have difficulty discerning what I'm talking about in terms of distinction. Anyways, but I think if you're reading this, hopefully you can figure out what they're talking about with reasonable clarification or understanding. Anyway, bleed appears like a starfish or sand dollar. Question can say that there is blood visualized in the basal cisterns. And so you can see that sand dollar shape right there for the brain. Treatment is usually supportive. Hypertension can be controlled. Anticoagulants must be reversed, i.e. fresh frozen plasma or patients on warfarin. Nimodipine can prevent vasospasm and neurologic sequelae due to convalescence. Well, this is interesting. Intracerebral hemorrhage. Rupture of the Charcot-Bouchard microaneurysms within the lenticulostriate arteries in patients who have chronic hypertension. Can present on USMLE as having a 1 to 2 stem without any image or patient info. Let's just say X person has a bleed plus decorticate posturing. What's the diagnosis? The answer should be intracerebral hemorrhage. So that's, again, person has a bleed plus decorticate posturing. In other words, USMLE wants you to know the intracerebral hemorrhage has a high likelihood of causing brainstem compression. What about let me continue with the with this one right here, intracerebral hemorrhage. Associated with Alzheimer's disease, that is to say amyloid angiopathy, which presents in Alzheimer's as a recurrent hemorrhagic stroke, can be associated with brain cancer as well, that is to say, for example, glioblastoma multiforme. Pituitary apoplexy, bleeding into the pituitary gland, can cause bitemporal hemianopsia. USMLE wants you to know that this can occur purpurium and also due to tumors. 2CK form gives a bitemporal hemianopsia in a woman who just gave birth, where the pituitary apoplexy is only answer listed that could cause this visual pattern. So again, bleeding into the pituitary gland, this can cause bitemporal hemianopsia. So let me look something up quickly. Maybe this is let's see. So puerperium is the 6-week postpartum period following childbirth, and the maternal body transitions back to its normal non-pregnant state. Okay, good to know. So we're on Cushing reflex now. I want to see where we are in terms of time. We have 15 minutes. I might take a brief break. Okay, so let us continue again. Talking now about Cushing reflex. Cushing reflex is a triad seen with elevated intracranial pressure where the patient will have a 1. Hypertension, 2. Bradycardia, and 3. Respiratory disturbance, classically a decrease in respiratory rate. But there's an NBME question where they don't give you the respiratory rate as decreased. So it's not necessarily a hard rule. Elevated intracranial pressure causes compression of the intracerebral vessels, leading to chemoreceptor sense to decrease oxygen delivery, plus elevate the carbon dioxide, meaning that this causes a sympathetic activation and vasoconstriction of peripheral arterioles, which means you're going to have an elevated BP, which means you're going to have an elevated stretch of the carotid sinus baroreceptors, which means you're going to have an elevated cranial nerve 9 afferent firing to the solitary nucleus of the medulla. This will cause an elevation in the cranial nerve 10 efferent firing to the nodal tissues, decreasing the heart rate. The decrease in respiratory rate is due to the elevated intracranial pressure causing compression of the brainstem. NBME will give you a big 15-line paragraph which patients who's been in an accident plus you ask for the reason for this or her hypertension, and the answer should just be increased intracranial pressure. Do not confuse Cushing's reflex with Cushing's ulcer, completely unrelated, which is the head trauma causing vagal overflow, increased acid production, plus peptic ulcers. So here's the actual Glasgow Coma Scale, GCS, which now only is explained with the little parentheses and side by side with the actual name, now after it's been mentioned already, by acronym first, so whatever. Glasgow Coma Scale, response scale score. So eye-opening response, so 4 to 1 scale, the lowest you can have is 1 for each of these categories. So eye-opening spontaneously, eye-opening to verbal command, speech or not, speech or shout, eyes open to pain, not applied to face, no eye opening. What about verbal response? So, 5, top response oriented. Next would be confused conversation but able to answer questions. Then inappropriate response, words discernible. Then incomprehensible sounds or speech. And then finally, lowest would be no verbal response. What about motor response? Obeys commands for movement, purposeful movement to painful stimulus, withdrawals from pain, abnormal spastic flexion, decorticate posture, extensor rigid response, disturbed posture, and then finally the lowest one would be no motor response. So if you had a very high Glasgow score between 13 and 15, you're basically top scoring almost everything, because I think top score you can get is 15. Then you have some minor brain injury. If you have it between 9 and 12, we have clearly some deficits, it's going to be moderate brain injury. If you only have 3 to 8 points, remember 3 is the minimum score you can get, you have a severe brain injury. It is, to my observation across NBME exams, but in particular the 2CK Neuro CMS forms, that they will never ask you to formally calculate the GCS score. What will occasionally surface on the NBME question is decorticate or decerebrate posturing, where you have to know, oh, that means GCS is low, patient has compromised brain function, possibly a herniation, and an increased intracranial pressure, ICP. And as I mentioned earlier regarding the suspected meningitis diagnostic workup, if the GCS is not 15, then head CT should be done before the lumbar puncture. Okay. Herniation types. They ask this on the 2CK form where they list different types of brain herniations where you're supposed to diagnose which one it is. So there's A, B, C, D, E, and F, and we'll explain hopefully what that is. So A, see A right there? That is a cingulate or subfalcine herniation. It doesn't usually produce specific symptoms, but it can compress or can compromise blood flow in the anterior cerebral artery, which is necessary for the contralateral motor sensory to the leg. The cingulate gyrus shifts under the falx cerebri. What about B? B right here, that's going to be called transcalvarial. So transcalvarial, symptoms vary based on the herniated tissue, ranging from no symptoms to seizures or focal neurological deficits. Brain tissue extrudes through a skull defect. What about C? C would be a central transtentorial. Decreased level of central transtentorial herniation, right? decreased level of consciousness, and bilateral motor abnormalities, the diencephalic structures move downward through the tentorial notch. What about D? D would be an uncal herniation. That's classic. Ipsilateral mydriasis plus a contralateral motor deficits involves the medial temporal lobe, the uncus, shifting into the tentorial notch. The ipsilateral mydriasis is due to the cranial nerve 3 compression. The contralateral motor deficits are due to the compression of the cerebral peduncle. And then we have E. Let's go up a little bit. E, which is an upward transtentorial herniation, decreased level of consciousness, pupillary changes. The diencephalic structures move upward through the tentorial notch. And then finally, F, tonsillar herniation, life-threatening respiratory and cardiovascular compromise. Cerebellar tonsils move downward into the foramen magnum, compressing the brainstem, and can cause decerebrate or decorticate posturing. Post-concussion syndrome. A concussion is a type of traumatic brain injury caused by a blow to the head or by a sudden movement that results in brain moving rapidly inside the skull. The rapid movement can cause brain cells to stretch and become damaged. Post-concussion syndrome, aka post-concussive disorder, comprises a range of symptoms that can persist for weeks, months, or even years after a concussion. Some symptoms include cognitive disturbance, memory loss, headache, and sensitivity to light or sound. USMLE will ask for a diagnosis right up onto CK forms. The base of skull fracture. Fracture at base of the skull, you would never have guessed it. Classic tetrad of signs is 1. Battle sign, which is bruising over the mastoid process behind the ear. 2. Raccoon eyes, which refers to bilateral periorbital ecchymoses, bruising around both eyes. 3. Otorrhea, CSF leaking out of the ear. And 4. Rhinorrhea, CSF leaking from the nose. Hemotympanum can also be seen, which is blood visualized behind the tympanic membrane. CNS malignancy can present with seizure and or morning vomiting, a sign of elevated intracranial pressure. Can be described as a ring-enhancing lesions, that is to say, this descriptor is not limited to toxo or toxoplasmosis. It can also be used to describe tumors/metastases and abscesses. PEDS brain tumors, pilocytic astrocytoma, most common brain tumor in kids, has solid white and cystic black components on imaging, not aggressive. Medulloblastoma, aggressive brain tumor of the cerebellum, can cause truncal ataxia if located at vermis, ipsilateral limb ataxia if lateral. Craniopharyngioma, most commonly pituitary tumor in children and teenagers, bitemporal hemianopsia, can occur with any pituitary lesion. Embryo is that it originates from the roof of the primitive oropharynx or roof of the primitive oral cavity. It can calcify and contain cholesterol crystals, high rate of recurrence. Do not confuse that embryo with the endoderm of the foramen cecum, which refers to thyroglossal duct cyst. Pinealoma can cause a vertical gaze palsy in kids, Perinaud syndrome. Hamartomas, the tubers in the tuberous sclerosis are hamartomas, which are described by paraventricular or cortical nodules on imaging. Okay, we're close to 30. I might just take a brief break and then come back in. Again, skip forward if you're watching a recording. Anyway, I'm back. I feel like I'm not very locked in the last few days, you know? Anyways, I'm ahead of my study schedule, technically speaking, but on this front of readings, technically speaking. But I still feel, my ethics, my work ethic, you could say, my study ethic could be improved, perhaps. Nevertheless, let's try to finish up this chapter. Adult brain tumors, glioblastoma multiforme. Most common adult brain tumor aggressive, aka butterfly glioma, since it can cross through the corpus callosum. Heterogeneous in appearance due to the areas of necrosis and hemorrhage. USMLE wants you to know that the glioblastoma multiforme is a grade 4 fibrillary astrocytoma. Meningioma, benign tumor that grows from the meninges and appears to sit up on top of the brain. NBME question floating around gives you one that they describe as adjacent to falx cerebri. It can also occur within the spinal canal, overlying the spinal cord on NBME. Schwannoma arises from the Schwann cells, which are responsible for myelinating peripheral nerves. Vestibular schwannoma arises from cranial nerve 8, vestibular cochlear nerve, often at the cerebellopontine junction, and can cause tinnitus and or vertigo. Can be idiopathic or as part of the neurofibromatosis type 2, NF2. USMLE wants you to be able to identify its growth as causing sensorineural hearing loss, like the RINA test would show that the air conduction is better than the bone conduction, while Weber test will lateralize contralaterally. Prolactinoma, most common pituitary tumor in adults. It can cause amenorrhea in women and impotence in men. Galactorrhea can occur in everyone. I discuss other pituitary tumors and hormones in detail in my high yields endocrine PDF. Optic glioma, seen in neurofibromatosis type 1, NF1. Oligodendroglioma, tumor of the oligodendrocytes, the cells that normally myelinate CNS neurons. Histo has a fried egg appearance and chicken wire capillary pattern. Ependymoma, tumor of the ependymal cells, which normally produce CSF. Rosenthal fibers on histo, eosinophilic corkscrew filaments. Tumor of the foramen of magnum. Can it cause hypoglossal nerve, cranial nerve 12 palsy, leading to ipsilateral tongue deviation, shows up on 2CK form. So you should know that the cranial nerve 12 lesion occurs from medial medullary syndrome as well as tumors of the foramen magnum. Metastases can be described as lesions at the gray-white junction. Choriocarcinoma and lung cancer love to metastasize to the brain. So choriocarcinoma and lung cancer love to metastasize to the brain. Bear that in mind. What about tic disorders? Tic disorders, Tourette syndrome, neurologic disorder characterized by repetitive involuntary movements and vocalizations, tics. Motor tics range from mere eye blinking, head jerking, or shoulder shrugging to more complex movements such as hopping, twirling, or even mimicking others' actions. Vocal or phonic tics include throat clearing, sniffing, or humming. More complex vocal tics can involve repeating words or phrases or shouting inappropriate words. Coprolalia. That's pretty. People think about Tourette's, they think about that kind of stuff. That latter thing of coprolalia. Haloperidol and clozapine are two agents used for treatment that show up on the NBME. Provisional tic disorder. In pediatrics, it is normal for the kid to sometimes have a singular tic that lasts up to a year, that is to say, unusual tongue or lip gesture. There is very low chance of it progressing to a chronic tic disorder like Tourette's. USMLE wants follow-up in 3 to 6 months as the next best step, i.e. observe. Okay. PANDAS. We talked about this before in a previous video. As mentioned earlier, there is an obscure condition called pediatric autoimmune neuropsychiatric disorder associated with streptococci, which is a lot less fun than panda bears are, but nevertheless, in this condition of PANDAS, where group A strep pharyngitis can cause a tic disorder, OCD, or ADHD in the weeks following infection. USMLE will give you a kid who has a sore throat 2 weeks ago, plus now has a new onset tic, ADHD or OCD, and they will ask you what will most likely diagnose as etiology for the disorder. The answer should be anti-streptolysin O titers. Drug-induced tic disorder. Stimulants such as methylphenidate, amphetamines, and caffeine can cause tics. Tardive dyskinesia due to antipsychotics is considered a type of tic disorder. Seizure terminology. FOAS, focal onset aware seizures, formerly known as simple seizures, no loss of consciousness. Okay, so that's FOAS, focal onset aware seizure. The name kind of implies what's going on, right? Focal onset impaired awareness seizure, formerly known as complex seizure, loss of consciousness is present. This includes staring into the space blankly, as with absence seizures discussed below. Partial seizures. One part of the brain is affected. Simple partial equals no loss of consciousness plus only affects one part of the brain. Complex partial equals loss of consciousness plus only affects one part of the brain. Generalized onset seizure, formerly known as a generalized seizure, dumb changes in nomenclature but I don't know what to tell you, involves both cerebral hemispheres, aka the grand mal seizure. Oh, sorry, this is the next category. So generalized onset seizure, previously called generalized, it involves both cerebral hemispheres. Okay. What about this tonic-clonic seizure, aka the grand mal seizure? It sounds like a Star Wars character, like a whatever. What's his name? Darth Maul, I guess, right? Yeah. Anyway, type of generalized seizure. It is characterized by two phases. Tonic phase lasts a few seconds, muscles stiffen, and the patient falls to the ground and loses consciousness. Clonic phase, rhythmic jerking movements of the limbs, usually last several minutes following the seizure, that is to say, during the postictal phase. The patient may be confused, drowsy, and have no recollection of the seizure. Tongue biting / lacerations are a high-yield post-seizure finding. If the question tells you explicitly that the tongue is normal and in this setting, they are telling you that it is not a seizure. Okay. Treatment for the recurrent seizures are agents such as valproic acid, so valproate, carbamazepine, and phenytoin. I discuss these later in the PDF in the pharm section. There is a difficult MBME question where they tell you the patient was twitching of one arm prior to falling to the ground and having a tonic-clonic seizure. The answer on the MBME form is complex partial, not generalized tonic-clonic. This type of seizure is called a focal onset, FOIAS, which is focal onset impaired awareness seizure with secondary generalization, or complex partial with secondary generalization. In other words, if the patient has a focal neurologic signs preceding a tonic-clonic seizure, this indicates an origin in one location prior to spreading to other areas. Status epilepticus. The updated definition is a seizure lasting greater than 5 minutes or two seizures within 5 minutes. Definition used to be a seizure lasting greater than 30 minutes or two seizures within 30 minutes. First line treatment would be a benzodiazepine. IV lorazepam is usually first line, but the USMLE does not care. If the benzodiazepine does not work, phenytoin or phosphenotoin is next, followed by barbiturates. In other words, for USMLE, benzo equals benzo, then phenytoin, then a barbiturate. That is to say, for example, pentobarbital. So benzo is number one, though. Myoclonic, a type of generalized seizure that causes muscle jerks lasting less than a second. A succession of jerks can be seen over a short period of time. The patient will not have a loss of consciousness. It can present similarly to simple partial despite the EEG showing generalized activity. Febrile seizure. Fever can precipitate idiopathic seizure in 2 to 4% of children ages 6 months to 5 years, about a twofold risk progression to epilepsy compared to general population. The treatment should be benzodiazepine. Febrile seizures lasting longer than 10 minutes, seizures that are recurrent within 24 hours, or focal neurologic signs, more specifically elevated risk of progression to epilepsy. Absence seizure. Vignette will be a kid staring off into the space in class for 30 seconds spacing out, sometimes with rapid blinking. This is considered loss of consciousness. EEG shows symmetric 3 Hz spike and wave discharge. Treatment would be ethosuximide, thalamic calcium channel blocker. We're going to talk about epilepsy disorders now. So temporal lobe epilepsy. Most common epilepsy disorder originates at the medial temporal lobe. Seizures are often preceded by visual auras or warning signs. These can manifest as gustatory/olfactory sensations or deja vu. Foyas, again, that's focal onset or impaired something. Focal onset impaired awareness seizures are most common type with or without secondary generalization. For USMLE, pick medial temporal lobe or just temporal lobe if they ask you for the origin of the seizure in the absence of any preceding neurologic findings. Okay. West syndrome. We're still talking about epilepsy disorders here. So West syndrome, aka infantile spasms, X-linked recessive. Epilepsy syndrome in infants characterized by, you never guess it, spasms, causes an abnormal EEG pattern called hypsarrhythmia, which is chaotic pattern, leads to intellectual disability. Treatment is with an ACTH, obscure but apparently elevated endogenous cortisol, which can mitigate the progression. Lennox-Gastaut, severe, or I don't know if it's French, in that case it might be like Lennox-Gastaut, whatever, or Leno-Gastaut, I don't know, who cares. Lennox-Gastaut, severe childhood onset epilepsy characterized by a near daily seizures and cognitive decline. Hyperauralism is a sign of cognitive regression. Babies put things in their mouths. Poor prognosis with 5% mortality rate in childhood, 80 to 90% persistence of seizures in adulthood. What about JME, juvenile myoclonic epilepsy, characterized by myoclonic jerks, usually hypnagogic or hypnopompic, that progress to tonic-clonic seizures after several months. Age of onset is usually 10 to 16, but also start in childhood. The treatment for this would be valproic acid. Now, we mentioned hypnopompic and hypnagogic already before. So I want to define that right now. I want to make sure I'm not missing anything. And these are kinds of hallucinations. But let's see. Hypnagogic refers to the transition state of falling asleep, while hypnopompic refers to transition waking up. So pomp, remember, it refers to like sort of this travel. So like a psychopomp is like the one who guides the soul. So that'd be like Dionysus or Anubis or one of these kinds of gods in the Greek and the Egyptian traditions, respectively. Or like Hermes could be a psychopomp, technically. But in this case, we're talking about a hypnopomp, right? We're talking about something that's guiding you into the realm of sleep, or guiding you out of the realm of sleep, I guess in this case. It's guiding the sleeper. So the hypnopompic is this guide from sleep into being awake, basically. The hypnagogic, I don't know. What does gogic mean technically? Let me look it up. Hypnagogic etymology. Hypnagogic comes from the French hypnagogique, combining the Greek words hypnos, sleep, from the agogos, leading or inducing. So, hypnagogic means to induce sleep. Hypnopompic refers to awaking from the sleep, or leaving the realm of the sleeping into the realm of the awakened people, I suppose. Anyway, so JME, juvenile myoclonic epilepsy, you will see seizures with both the beginning of sleep and the beginning of awakening. What about conditions misconstrued as seizures? Adams-Stokes attack, idiopathic arrhythmia disorder in peds that causes transient hypoxia to the brainstem, resulting in seizure-like episodes. EEG does not show any seizure activity. Question will give you a kid with miscellaneous arrhythmia description plus describe twitching that sounds like a seizure. The answer should be Adams-Stokes attack. What about breath holding spell? They'll say a 3-year-old was having a tantrum followed by falling on the floor plus appearing blue. Child will involuntarily stop breathing following a trigger, that is to say being upset, frightened, or experiencing pain. The child often cries or becomes upset, exhales forcefully, stops breathing, and then develops cyanosis, which can sometimes be followed by a brief loss of consciousness, and jerking can be mistaken for a seizure. Shows up on MBME, so you need to know it exists. Well, that's pretty crazy. Kid gets so upset they stop breathing? That's crazy. Syncope. Just be aware that syncope is in elderly, that is to say, from aortic stenosis or AFib, can sometimes cause twitching or muscles that accompanies fainting, where it resembles a seizure. The muscular activity is due to the hypoxia to the brain, similar to Adam Stokes' attack. Shows up on the NBME form as an elderly patient with cardiovascular history who has seizure-like episode. Vignette might say there is no evidence of tongue biting, meaning not a seizure. High-yield peds neuroconditions. Spinal muscular atrophy, aka Verdnig-Hoffman syndrome. Genetic disorder affecting the anterior horns. Presents with profound hypotonia, absent reflexes, and tongue fasciculations. Cerebral palsy. Motor dysfunction and intellectual disability of varying severity, posited to be due to the intrapartum conditions such as hypoxia. Will show up on USMLE as a spastic paraparesis in a child who has scissoring of the legs. Okay. Chiari 1. Downward displacement of the cerebral tonsils into the foramen magnum, usually teenager or young adult. Presents with headaches and neck pain, but can also be asymptomatic. What about Chiari 2? Herniation of both the cerebellum and brainstem through the foramen magnum and is commonly associated with meningomalaceal. Presents as a child with dysphagia and motor dysfunction. What about Dandy-Walker syndrome? Absence cerebellar vermis plus cystic dilation of the fourth ventricle. Fetal alcohol syndrome. Let me go back a little bit. Okay. Fetal alcohol syndrome. Most common cause of mental retardation. That's interesting. Heart-lung defects, defective neural crest migration, smooth, flat, and or elongated philtrum. Thin vermilion border, thin upper lip, widely spaced eyes, hypertelorism, mid-face hypoplasia, short nose. Phenylketonuria, autosomal recessive, deficiency of phenylalanine hydroxylase, or rarely a THB, which is a cofactor for the enzymes, causing an inability to convert the phenylalanine into tyrosine. Screen for on heel prick test at birth, since failure to detect PKU will result in mental retardation. Phenylalanine deficient diet must be given. Presents as a child with a mousy or musty body odor that plus appears lighter skin than siblings. Can cause partial albinism since tyrosine is normally converted into melanin and tyrosine cannot be synthesized. What about maple syrup urine disease? Autosomal recessive, deficiency of branched chain ketoacid dehydrogenase, inability to break down leucine, isoleucine, and valine. Causes a maple syrup descent in the diapers from the urine, mental retardation, and neurologic abnormalities if untreated. That's important to be aware of. Same thing with PKU. Serious consequences if it is not treated early on. Cretinism, aka congenital hypothyroidism. Most common causes are iodine deficiency in the mother during pregnancy worldwide and fetal thyroid dysgenesis in Western countries. Leads to the mental retardation, poor myelin sheath development, impaired bone growth, hypotonia, macroglossia, and protuberant abdomen due to umbilical hernia. Can be confused with Kashiorkor disease, which is protein calorie malnutrition causing ascites. Screened for a birth using a heel prick test to prevent exacerbation. Waardenburg syndrome. Congenital sensorineural hearing loss plus pigmentary changes in hair and skin. Shows up on the NBME as a young child with a white forelock of hair. That's interesting. Answer should be a failure of neural crest migration. Waardenburg syndrome, a white forelock of hair. That's a very unique characteristic. I don't think I've heard that one before. Maybe I've heard. I think might have heard of Waardenburg syndrome before, but it's definitely not something you hear a whole lot about, I guess. And I think that's a very unique trait, perhaps. So if you hear that, start thinking about that. Anyway, double cortex syndrome, obscure condition when asked on USMLE, students are hysterical about. Genetic condition where neurons are unable to migrate outwardly to reach their destination in the cortex, resulting in 2 gray matter layers, cortex instead of 1. Mechanism USMLE wants is failure of radial migration. Rett syndrome, neurologic degeneration that occurs exclusively in female infants. Hand wringing or hand flapping is Buzzy finding. Mental regression can present as putting objects in one's mouth. Sometimes babies normally do. Cri-du-chat, deletion of the short arm of chromosome 5 results in the distinctive cat-like cry during infancy, which is the source of the syndrome's name. French for cry of the cat. Cri-du-chat. Cri, cry, du, of, shot, cat. So, like, for an example, in English we say of, and in the German you might say, for like a name, for example, they might say zu or von, for example, like von, von, or they might use the word, I think they use zu for like a surname that's a nobiliary particle, zu. And for French you'd use du or de, like Dupont, for example. And Spanish you would use de. Portuguese I think you use de, and I think Italian you use de, basically. So de Trastamara, de Cortez, de, I don't know, whatever you want to say, right? But in French it's du, means of. Friedreich ataxia. As mentioned earlier, autosomal recessive GAA-TNR disorder causes ataxia, kyphoscoliosis, cardiomyopathy, pes cavus, high arched feet, hammer toes, and early onset type 2 diabetes. Angelman syndrome, happy puppet, that is to say, child presents with laughter, paternal imprinting, gene coming from dad is normally silenced, mom's gene is supposed to be expressed but is deleted or mutated. Mom is not an angel because mom's gene is deleted. Okay. Even if a dad's gene is healthy, since it is normally silenced, it will not be expressed. Oh, weird. Oh, yeah. Okay, I see what you're talking about. Because it's silenced, so it's not going to be expressed. Can also be caused by paternal uniparental disomy, since the gene is normally paternally imprinted. If both alleles are inherited from the dad, both will be silenced. Oh, weird. Okay. Disease occurs because there is no maternal allele available to be expressed. How weird. Prader-Willi syndrome, mental retardation plus hyperphagia. Maternal imprinting, gene comes from the mom and is normally silenced. The dad's gene is supposed to be expressed but is deleted or mutated. Willie hates his dad because his dad's gene is deleted. And hence the gene is supposed to be expressed. Even if the mom's gene is healthy, since it's normally silenced, it is not expressed. It can also cause maternal uniparental disomy, since the gene is normally paternally imprinted. If both alleles are inherited from the mother, both will be silenced. Disease occurs because there is no paternal allele available to be expressed. That's really interesting. There is different ways that the body expresses different genes and stuff like that, but I guess I never really thought about, this is kind of funny for me because I'm interested in genetics to some degree or another, but I never really thought about the situation of like a normative situation where like it's the norm for the body to simply defer to one copy of a gene because it's from one parent or the other, and disregard the other one and silence it because it's paternal or maternal, rather than because there's a normatively dominant version of or allele that might be present. So, for example, if you have rhesus positive, rhesus negative, you will have one is going to be dominant, the other one's not going to be dominant. If you have something like AB blood, it's co-dominant. So the phenotype will have a co-dominant A and B presentation. But what they're saying here is that Angelman, because the genes related to Angelman is always going to be dominated by the mother, even if the mother's gene is not present, it's still not going to be expressed at all because they just don't care what the father's presentation is. And for Prader-Willi syndrome, it's the opposite. The paternal version of the gene is always going to be expressed, and so there's no gene from the father there. It just will not express the gene at all, which is really, really weird. Okay. So that's a different mechanism of expression that I'm familiar with, I think, and one that's I think most people are not as familiar with as something as more normal as, let's say, for example, codominance versus heterozygous dominance of one or the other, that kind of thing. Rinne plus Weber tests. Rinne test: a vibrating tuning fork is placed against the mastoid bone conduction, BC. Once the patient can no longer hear it, it is removed from the bone and placed in front of the ear canal, air conduction, AC. For both normal hearing and sensorineural hearing loss, the AC should be greater than the BC. But for conductive hearing loss, BC will be greater than AC. So if you ever have BC greater than AC, you know it's probably going to be a conductive hearing loss. But if AC is better than BC, it might be normal, but it doesn't rule out sensorineural. What about Weber test? A vibrating tuning fork is placed on the center of the forehead or top of the head, and the patient is asked whether they hear the sound equally in both ears or if it's heard louder in one ear. If it's louder in one ear, this is called the lateralization to that ear. So let's talk about it a little bit. Normal hearing, Rinner shows air. So normal hearing, the Rinner will have the air conduction greater than bone conduction. Well, the Weber test does not lateralize because there's no ear deficiency. What about conductive hearing loss on the left ear? Well, in that case, the Rinner test will show that the bone is greater than the air conduction. True. And the Weber will lateralize to the louder side on the left for conductive hearing loss. So the conductive hearing loss is on the left, it will lateralize to the left, which is the louder side. Conductive on the right is the inversion of that, basically, for that latter test. Still, Rinner still shows that the bone conduction is greater than air conduction, and the Weber will lateralize this time to the right because it's on the right side, and that's the louder side. What about sensorineural hearing loss? Well, in this case, this is the returns back to normal. For sensorineural hearing loss on the left, you'll have Rinner test shows the air is greater than bone conduction. That's normal. However, the Weber will lateralize to the right, which means that you have a left-sided hearing loss because if it's sensorineural, that means that left side is weaker, right? Is impaired in some way. What about sensorineural on the right? In that case, then it's still going to be a normal presentation for Rinner test. Shows the air is greater than the bone conduction. However, it will lateralize to the left, which means that the right side has an impairment if it's sensorineural in origin. Okay, we're on page 273 right now. We want to wrap up on 278. We are currently where are we currently? About an hour and 3. So basically, I took a half hour to cut through. So I will be back with you in a few minutes. Skip ahead if you were watching a recording. Well, I am back, and well, let's see how things go. I suppose that wasn't too bad. I don't believe. Well, I was gone a little bit, 5 minutes ish, kind of. Let's see. What do we have? We have 273. We want to wrap up 278. So we're kind of in the back end, you could say. Cholinergic concept review. If an agent is cholinergic, it will cause dumbbells, signs and symptoms: diarrhea, urination, meiosis, bradycardia, bronchoconstriction, neuromuscular excitation, lacrimation, salivation, and sweating. If an agent is anticholinergic, it will cause the opposite of dumbbells, or anti-dumbbells: constipation, urinary retention, mydriasis, tachycardia, bronchodilation. In reality, beta-2 agonism, but not muscarinic antagonism will be bronchodilate. Okay. Skeletal muscle relaxation, dry eye, dry mouth, anhidrosis. The reason knowing this stuff is important is because the TCAs, that is to say, for example, amitriptyline, antipsychotics, and first-generation H1 blockers, that is to say, diphenhydramine or chlorpheniramine, have strong anticholinergic side effects, which means that they can cause anti-dumbbells in any patient. In addition, anticholinergic effects promote delirium and confusion, especially in the elderly. For example, old dude plus high creatinine plus on amitriptyline equals post-renal azotemia due to the combination of the BPH, which all old dudes have, which is the benign prostatic hyperplasia, and the TCA, which is an anticholinergic. You want to take care of him, so you want to take him off the anticholinergic medication he is on. Likewise, if you get a psych question where the patient has confusion or delirium, and one of his or her drugs is diphenhydramine, the answer might be discontinue the anticholinergic medications. Cholinergic agents either are 1. Agonize the cholinergic receptors directly, or 2. Increase the potentiation of acetylcholine binding to its receptors by inhibiting the acetylcholinesterase, the enzyme that breaks down acetylcholine, thereby increasing acetylcholine within the synaptic cleft. Almost all of the anticholinergic agents block cholinergic receptors directly. What about the so now we're talking about these medications now, I suppose. Pro-cholinergic medications. Muscarinic receptor agonists. We have bethanechol, stimulates the detrusor muscle, used for overflow incontinence in diabetic patients with neurogenic, that is to say, hypocontractile bladder. Carbachol constricts people and lowers the intraocular pressure, used for glaucoma. See my high-yield ophthalmology PDF for more detail on that stuff. Pilocarpine constricts the pupil and lowers the intraocular pressure. Powerful agent used for closed-angle glaucoma. Methacholine causes bronchoconstriction, used to help diagnose asthma. It is administered to a patient not during acute attacks. Spirometry will worsen and asthma symptoms may be replicated. What about acetylcholinesterase inhibitors? Donepezil increases the acetylcholine available in synaptic cleft, i.e. procholinergic, used first line for Alzheimer's disease. Galantamine and rivastigmine have the same MOA in the same case, but are low yield. Androphonium, aka Tensilon, the brand name, short-acting acetylcholinesterase inhibitor, administration to patients with myasthenia gravis causes marked improvement in symptoms and muscle function. Administration to patients with Lambert-Eaton syndrome does not result in as marked improvement of symptoms. Yeah, that's an important thing to distinguish. If you are debating between LES versus MG, myasthenia gravis, versus Lambert-Eaton, Lambert-Eaton is not going to be meaningfully improved by the androphonium tensilon test, but myasthenia gravis would be. You see what I'm saying? Also, if you have a cholinergic excess, let's say, for example, you have way too much of these anticholinesterase inhibitors or whatever that you would have, right? Like, let's say you have an excess of a one of these things like pyridostigmine, for example, physiostigmine, you way too much. Well, then a tensilon test would also, it might present similar to what you would have if you had myasthenia gravis in and of itself without enough treatment. And so you have this kind of question of like, do I have too much or too little? Well, if you take a tensilon test and it shows no improvement, or it gets worse, that means you have too much. If it shows improvement, that means you weren't taking enough, and then you need to up your dose or lower the dose contrarespectively based on the current circumstances. Make sense? Because the excess and the deficiency have similar presentations, you might use a tensilon test or hydrophonium test in a similar way to help distinguish between whether or not it's too little or too much. But yeah, Lambert-Eaton syndrome also is not meaningfully improved by it. What about pyridostigmine? Treatment for myasthenia gravis. Physiostigmine, antidote for Jimson weed poisoning, aka on NBME. Jimson weed contains atropine-like compounds that are anticholinergic. Neostigmine, used post-surgically to reverse the effects of the neuromuscular blockade. Toward the end of surgery, administration helps increase the availability of acetylcholine so that it can bind to its receptors and displace the nicotinic receptor antagonist used for the neuromuscular paralysis. Organophosphates. Vignette will either be a backpacker in his 20s or backpacker in his or her 20s picking fruit on a farm, or someone who drank fluid in a suicide attempt. The phosphate group binds to the acetylcholinesterase, inhibiting it. NBME question asks how toxicity can be prevented. The answer should be wearing gloves, where wearing gloves is wrong answer. Oh, great. So acquisition occurs mostly through the skin. USMLE wants atropine first, followed by pyrroldoxime as the treatment. Oh, I'm sorry. I read that incorrectly. Wearing gloves is the answer. Wearing a mask is the wrong answer. And the reason why wearing a mask is the wrong answer is because it's spread through the skin. So if you're messing around with the plants and it has these organophosphates on it and you get sick from it, how would you prevent it? Wearing gloves. Mask wouldn't help, okay? USMLE wants atropine first as a treatment, followed by pyrroldoxime as a treatment, as discussed below. So number 1, atropine. Number 2, pyrroldoxime for organophosphate poisoning. And again, we're talking about before, the physiostigmine is an antidote to atropine. So if you have organophosphate poisoning, what do you give? Atropine potentially. Atropine is number 1. If you have a atropine poisoning or a Jimson weed poisoning, which has an atropine-like compound, what do you give them? Physiostigmine. So these are kind of like counterbalancing sort of effects of these agents. Some of them simply toxins that you can introduce to, and in the other cases we're talking about obviously medications which have the intended reverse effect. What about anticholinergic medications? Muscarinic receptor antagonists. Atropine, classic textbook drug that is used to block muscarinic receptors, can be used to increase heart rate during surgery, given as a first-line treatment for organophosphate poisoning before pyrroldoxime. Pyrroldoxime is a special anticholinergic that works by regenerating functional acetylcholinesterase by kicking out the phosphate group that inhibits it. What about benztropine? Used for acute dystonia due to antipsychotics. In other words, if the patient starts an antipsychotic and then within hours to days gets stiff neck, torticollis, the muscle rigidity without fever, and or abnormal eye movements, ocular gyre crisis, this is called a first-line treatment. Muscle rigidity, fever, in contrast, suggests a neuroleptic malignant syndrome. Diphenhydramine, first-generation H1 blocker that has a strong anticholinergic side effect to the point that is often just characterized straight up as a primary anticholinergic medication, can be used same as a benztropine for acute dystonia. USMLE won't list both. Can be used for motion sickness. Anticholinergic effects treat motion sickness. If the USMLE tells you that it's used in this setting, plus they ask for your antagonism of which receptor, it enables its anti-motion sickness effect. The answer is M3. The wrong answer is H2. Since this refers to stomach acid secretion, diphenhydramine is an H1 blocker, not H2. Most questions on USMLE regarding diphenhydramine revolve around you knowing it should be discontinued from a patient's regimen rather than added. Prochlorperazine, antipsychotic used as an anti-nausea medication. Even though it is a D2 receptor antagonist, as I mentioned before, antipsychotics have an anticholinergic side effect. In this case, antimuscarinic side effects are actually a good thing since these treat nausea and motion sickness. Ipratropium, one of the first-line agents used for COPD, S1,2-CK, and NBME. COPD patients can be started on either a muscarinic receptor antagonist such as ipratropium or a beta-2 agonist such as olodaterol. New literature gets pedantic about this duration, that is to say, long-term versus short-term acting, or long versus short acting. Antimuscarinics have a beta-2 agonist and beta-2 agonist, but USMLE does not, i.e. some sources say tiotropium is recommended over ipratropium first line now, but I've had students come out of this exam saying ipratropium showed up, but that it didn't matter since it was only the drug listed that worked anyways. So it might be that tiotropium is preferred now for COPD, but ipratropium is still a pretty good first line agent for COPD. If you had to choose between the two, maybe you would choose tiotropium, but I don't know. And the other is he's not 100% sure either. So, and again, it's a muscarinic receptor antagonist such as ipratropium, or beta-2 agonist such as allopurinol, which is going to be used for COPD. Oxybutynin, used for urge incontinence. Oxybutynin. Okay. Scopolamine. Scopolamine patches are used for motion sickness, i.e. put in the arm before getting on boats or planes. This drug is an anticholinergic straight up. As mentioned above, oral diphenhydramine can also be used for motion sickness, but scopolamine is a classic treatment. Hyoscyamine, used sometimes for irritable bowel syndrome. So those were all, in that case, these were all muscarinic receptor antagonists, all that stuff right there. What about non-depolarizing nicotinic receptor antagonists? Well, we have tubercularine. A non-depolarizing means the agent does not cause any action potentials. The NBME question mentions a non-depolarizing agent used for neuromuscular blockade during surgery, and the answer is just tubercularine straight up. What about vecuronium? These are for paralysis during surgery. Cisatricurium and rocuronium are other important agents as well. So those are the non-depolarizing nicotinic receptor antagonists. What about the depolarizing nicotinic receptor agonists, such as which acts as an antagonist? Well, succinylcholine is the one we're talking about here. That one's an interesting one. So let's talk about it. Succinylcholine functions as an antagonist due to the desensitization of receptors. It binds to the nicotinic receptors and agonizes them, causing the initial action potentials and muscle twitching, fasciculations, prior to desensitization and muscle paralysis. Akin to leuprolide causing a desensitization of gonadotropin-releasing hormone receptors with continued binding, where despite being a GnRH receptor agonist, it acts as functionally as an antagonist, can cause malignant hyperthermia, high fever, muscle rigidity, treat with dantrolene, which inhibits the ranitidine calcium channel. Now, I want to say this. There's two stages for succinylcholine effect. The first stage is what they mentioned. It's a sort of agonizing effect, but it's stage 2. It's still stuck to the receptors, and it's basically preventing any further action from occurring. And so now it's desensitized to what's going on, and that's the stage 2. So stage 1, it has an agonist effect. Stage 2 has an antagonist effect. That's the best way you can phrase it. Stage 1 and stage 2 do the opposite thing. They're acting on that. I think they're acting on the neuromuscular plate. So, yeah. Anyway, that's the depolarizing nicotinic receptor agonist, depolarizing type. What about smoking cessation agents? Bupropion, dopamine plus norepinephrine reuptake inhibitor, has an antidepressant effect. Also antagonizes the nicotinic receptors, which disincentivizes smoking, since doing so won't produce rewarding effects. So it does both things at the same time. It both inhibits the reward from doing smoking and also tries to dissuade smoking by having a sort of antidepressant effect, I guess you could say. So it's inhibiting smoking directly by trying to kind of satiate you a little bit, but also undermining the reward you get from smoking. But bupropion also lowers the seizure threshold, so be aware. Don't give the patients with eating disorders. Electrolyte abnormalities will increase the seizure risk. It does not cause sexual side effects, unlike SSRIs. What about varenicline? Used for smoking cessation, partial agonist at nicotinic receptors, but since this effect is less than endogenous acetylcholine, it functions like an antagonist. What about epilepsy and hypnotic agents? Well, USMLE doesn't care about MOAs for these, they do care about the side effects mostly, as per my observation. So valproate or valproic acid blocks sodium channels and GABA blocks sodium channel and elevates GABA. Used as an alternative to lithium in treatment for bipolar disorder, causes neural tube defects in pregnancy due to the interference with folate metabolism. Carbamazepine blocks sodium channels, generic anti-epileptic drug also used as prophylaxis for trigeminal neuralgia. Causes neural tube defects in pregnancy due to the interference of folate metabolism, can cause aplastic anemia and SIADH. Phenytoin blocks sodium channels, generic anti-epileptic, causes neural tube defects in pregnancy due to the interference of folate metabolism, can cause fetal hydrantoin syndrome, fingernail hypoplasia plus abnormal facies. Used for status epilepticus if benzos fail. Ethosuximide blocks thalamic calcium channels, only anti-epileptic, USMLE might ask MOA, used for absent seizures. What about benzodiazepines? Diazepam, lorazepam, midazolam, chlorodiazepoxide, etc. Benzodiazepines bind to the GABA-A receptor, which increases the frequency of chlorine channel opening. The frequency increases, okay? Thereby allowing chlorine to flow into the neuron, hyperpolarizing it and inhibiting it, i.e. decreasing the firing. The hypnotic induces sleep, anxiolytics, reduces anxiety, and anticonvulsant. Given first line for status epilepticus. Clonazepam, which is a benzodiazepine. Clonazepam used for insomnia/anxiety shows up on NBME. Used for stimulant intoxication like cocaine, amphetamine, PCP. So it can help manage that if you have that toxicity. Used for specific phobia, for example, fear of flying. Used for social phobia, second line if the patient has asthma, since we don't want to give propranolol in this setting, as on NBME. Okay, good to know. Used for alcohol withdrawal, delirium tremens, alcoholic hallucinosis. USMLE wants you to know that alcohol also binds to and activates GABA-A receptor, but at a different location from benzos. There is an NBME question where you have to select the illustration of an alcohol molecule and benzo binding to the same receptor, but at different sites. It can cause respiratory depression. You treat overdose with flumazenil, antagonist of the benzo receptor. What about barbiturates? Barbiturates, phenobarbital, thiopental, etc., binds to GABA-A receptor, elevates the duration of the chloride channel opening, making them more efficacious and dangerous than benzos. Again, that's an important thing to know. So before we were talking about the benzos elevate the frequency of the chlorine channel opening. Now we're talking about barbiturates, which increase the duration of the chloride channel opening, making them more efficacious and dangerous than benzos. They're used for general anesthesia, used for unremitting status epilepticus if benzos and phenytoin fail. What about non-benzo hypnotics? So these are things that are acting on the same receptor, and they're hypnotic, but they're not benzos, and they're actually not as addictive. They're not really addictive at all. Zolpidem and Zaloplan. There's also azopiclone as well, which I think they don't mention that. So there's azopiclone, Zolpidem, and Zaloplan. Activate GABA-A receptor, but bind to a different subunit from benzos. Oh, I thought it was the same subunit. I didn't know that. I thought it was the same subunit. But regardless, it's the same chloride channel. It's not addictive in the same way. It can cause addiction similar to benzos. What? Are you serious? Okay, so this is like the opposite of what I was taught when I was in my earlier schooling. They say, oh yeah, non-benzo hypnotics like azopiclone, Zolpidem, so forth, they're acting at the same site, but they're not as addictive. He's saying here, they act at a slightly different site, and they are addictive potentially. I'll say this much. They are not as likely to cause addiction. They are less likely to cause addiction. Maybe they can cause addiction, but they are less likely to compared to benzodiazepines. That's why they're desirable for hypnotic purposes. Make sense? They're less likely to be dependent on it. Okay? It does not necessarily mean it's not possible, but it's less likely in comparison. Make of that what you will. And make of what you will about his comments, because this is a guy who tries to prepare you for these exams in the first place. So even if I want to say, your comment is maybe more accurate or whatever, he's focusing on what did the exam say. Okay, what does the exam understand things to be the case? Okay, whatever. Magnesium, used for treatment and prevention of eclamptic seizures in pregnancy, given to pregnant women giving birth, less than 32 weeks gestation for neuroprotection for the fetus, used for torsades, arrhythmia, and digoxin toxicity. Lamotrigine blocks sodium channels, general anti-epileptic, can cause Stevens-Johnson syndrome. What about drugs for neuropathic pain? TCAs prevents reuptake of, which is, I guess, that's tricyclic antidepressants, prevent reuptake of both the serotonin and the norepinephrine. Yeah, that's what it is. It is tricyclic antidepressant, which can be used for a neuropathic pain. Amitriptyline, norepinephrine, and imipramine. Neuro use case is a neuropathic pain, i.e. diabetic peripheral neuropathy, causes CCC, coma, convulsions, and cardiotoxicity, QT prolongation, and EKG, have a nasty anticholinergic side effect, cognitive dysfunction, and urinary retention, especially in elderly. Gabapentin blocks the calcium channels leading to neuroinhibition, used for neuropathic pain, that is to say diabetic peripheral neuropathy. So these are headache drugs. How long is the last page? It's somewhat. I'm just gonna take a brief breather. Okay, let's go back into it. Headache drugs. Migraine, abortive therapy, NSAIDs first, then sumatriptan, serotonin receptor agonist. Prevention would be propranolol beta blockade for prevention. Cluster headaches, what do? Abortive therapy would be oxygen. The prevention would be verapamil, non-dihydropyridine calcium channel blocker. Tension would be rest plus acetaminophen. Trigeminal neuralgia, abortive would be goes away on its own because the episodes last maximum 30 to 60 seconds. Okay, that's pretty short. Prevention would be carbamazepine, sodium channel blocker. They're very nasty, though. Very nasty thing to have trigeminal neuralgia. Parkinson's drugs. Carbidopa, levodopa. Combination frequently used for treatment of Parkinson's disease. Levodopa crosses the BBB to be converted into dopamine centrally. However, levodopa is subject to fast metabolism when administered alone, which means that if it becomes dopamine before it gets to the central nervous system, that means it's going to get stuck in the peripheral system and therefore not be useful for Parkinson's treatment. Not to mention the fact that dopamine, if it's in excess in the peripheral system, can lead to other sorts of secondary effects which are considered deleterious or negative or undesirable. Therefore, what do you want to do? The addition of carbidopa functions as a competitive inhibitor of breakdown enzymes. Sort of. It's more accurate to say that it's a inhibitor of a enzyme that converts it into dopamine in the first place, resulting in increased levodopa availability for passage across the BBB. So again, I've described this before in a previous video. So levodopa is converted into dopamine by, I think, dopa decarboxylase. Is that the correct enzyme? What converts L-dopa to dopamine? I think it's dopa decarboxylase. It says here, the enzyme, they have two different things. So yeah, aromatic L-amino acid decarboxylase, or AADC, also called dopa decarboxylase, DDC, converts dopa into dopamine. So also called levodopa. Levodopa is an enantiomer, you could say. Now, the point with that is this, is that you don't want a lot of peripheral conversion if you're going to introduce levodopa, because again, we want to have the central dopamine because you have Parkinson's disease. And you don't want to have a lot of these negative effects from dopamine in the peripheral system. So the way we minimize that is you prevent peripheral conversion. And bear in mind, again, levodopa can cross the BBB. Dopamine cannot cross the BBB itself. Only the levodopa antecedent can. And so you have to ensure peripheral conversion does not happen. And then you have enough time for the dopamine to get into the central system, where then it can be converted to dopamine. And that's why carbidopa is useful, because it prevents the conversion of levodopa into carbidopa it prevents the conversion of levodopa into dopamine before it crosses the BBB. Make sense? So saying metabolism or breakdown, that's not entirely a great description. Resulting in increased levodopa availability for passage across the BBB. Do not confuse this mechanism with the COMT inhibitors, like tolcapone and tacapone, which prevent breakdown of levodopa. That's true. That is an actual enzyme that breaks down levodopa, and tacapone and tolcapone can inhibit COMT. There's also such a thing as MAO, which also breaks down, I think, either dopamine itself or levodopa, I'm not quite sure. But MAO also has its own MAO inhibitors, which can mess with that as well. So bear that in mind. So MAO is one of them with MAO inhibitors. More relevant is COMT, which can be inhibited by tolcapone and tacapone, but also carbidopa, which messes with dopa decarboxylase, preventing levodopa from being peripherally converted. Okay. This is the assessed on 2CK psych forms, where there is a patient who gets psychotic episode followed by a recent addition of CL, carbidopa levodopa, to regimen, or following an increase in dose. The answer is simply decrease the dose of carbidopa levodopa. Discontinue carbidopa levodopa is the wrong answer. It's decrease, do not stop, okay? Even if you have a negative symptom, just decrease it. D2 receptor agonist. Ropinirole, pramipexole, cabergoline, pergolide, and bromocriptine used for Parkinson's disease management. Bromocriptine, classic agent used for prolactinoma. Dopamine agonism decreases prolactin. Ropinirole and pramipexole classically show up as restless leg syndrome treatment, following making sure that the patient is iron replete. New literature suggests that gabapentin is first line over the D2 agonist now for RLS, but USMLE won't play trivia. They will give patient with an RLS or restless leg syndrome and say, in addition to ropinirole, what else could be added? And the gabapentin will be the only answer listed that works. Amantadine, used for Parkinson's disease, increases the presynaptic release of dopamine. Selegiline, used for Parkinson's disease, inhibits the monoamine oxidase B, which is an enzyme that preferentially breaks down dopamine. Can cause serotonin syndrome either alone or in combination with drugs like St. John wort or SSRIs. Alzheimer drugs, donepezil, as mentioned earlier, this is a cholinesterase inhibitor such as used in Alzheimer's disease. Rivastigmine and galantamine you can be aware of and have some MOA but are low yield. Memantine, NMDA glutamate receptor antagonist, glutamate receptor activation normally causes the calcium to flow into the neuron, leading to the depolarization and neuroexcitation. In other words, USMLE wants you to know that the glutamate receptor is a ligand-gated calcium channel, where the glutamate is the ligand that activates the channel. Antagonism causes neuroinhibition. Neurotoxic drugs. Vincristine prevents microtubule assembly used in general chemotherapy. USMLE can ask what drug inhibits, and the answer is just tubulin. Peripheral/autonomic neuropathy. The answer shows up as toxic neuropathy on a 2CK neuro CMS form. Cisplatin, cross-linking agent used as a general chemotherapy, causes neuro and autotoxicity. Aminoglycosides. The 30S ribosomal subunit inhibitors used for gram-negative rods, highest yield use case is in combination with vancomycin as an empiric treatment for endocarditis. Gentamicin, tobramycin, and macacin, latter sounds unusual but shows up on the NBME, causes ototoxicity, sensory neural hearing loss and or vertigo, causes nephrotoxicity. Loop diuretics. Blocks the 1-sodium, 1-potassium, 2-chloride symporter on the apical membrane of the thick ascending limb of the loop of Henle. Furosemide, ethylcrenic acid, etc. can cause sensory neural hearing loss and or vertigo. Aspirin, irreversible cyclooxygenase 1 and 2 inhibitor, so COX-1 and COX-2 inhibitor. Most common symptom is tinnitus, ear ringing. Quinidine, 1A sodium channel blocker used occasionally as an antiarrhythmic, causes synchronism, which means headache plus tinnitus. Digoxin, sodium potassium ATPase inhibitor used for advanced heart failure, optic neuritis presenting as a yellow wavy Vincent van Gogh vision. Ethenbutal, arabinosyl transferase inhibitor used for TB treatment, causes optic neuritis, visual changes of any kind, blurry vision, central scotoma, red-green color blindness, and so forth. Sildenafil, phosphodiesterase 5 inhibitor used for erectile enhancement, Viagra, can cause blue haze. Apparently, this is due to its ability to also inhibit PDE6, found in the retinal receptors. Oh my gosh, tadalafil, Cialis, does not inhibit PDE6 the same way, so this is more just with Viagra. Step 3 wants you to know that pilots cannot take this within 3 hours of getting on an airplane due to the possibility of blue haze. Unusual obscure factoid, as if one would require a... Okay. Yeah, whatever. Haha, funny joke about penises. Okay, whatever. Anyway, that's the end of the chapter. Hopefully that was the end of the what we call the neuro chapter we have. The next chapter would be psych. I don't know if I'm going to read that right now or not, or if I will read it. I presumably will at some point. Presumably. But regardless, hopefully this video was of good use to you. Hopefully it was informative in some manner or another. This was the final video for the neuro section. This is definitely longer than the other two. But hey, it needed to be done, right? So anyways, if you like that video, smash that like button, leave a comment. I don't know, some of your house, I don't know. Like, whatever, subscribe, perhaps, right? Regardless, have a great rest of your day. Thank you, and goodbye.